What is the London AKI Network?
So London AKI Network is a clinical network of healthcare professionals based in London who are tasked improving the quality of care for AKI patients across the capital.
Why did this start?
So I think there were several of us had felt that AKI in London and perhaps more widely required a more strategic approach. So this is a condition that's relatively common, it's quite serious, it affects patients in all clinical areas in a hospital, and many of the patient pathways actually traverse organisations. So I think we felt that AKI care was not joined up or well organised or good, and we felt that to move forward with managing patients more effectively we needed to work more as a team. And I think this was also in a way influenced by the NCPOD 2009 report on fatalities of AKI, which one of the key recommendations was that the clinical areas looking after AKI patients, namely general medical areas, renal units and critical care units, should work together to agree standards and pathways and clinical guidelines together. And this triggered some thinking that we would need to do that on a cross-organisational basis, because of course in London renal unit specialist care is very centralised. We have ratios of up to 13:1 hospitals per renal unit, and this was not something that could be addressed just on an organisational level. This required organisations and the clinical leads of those organisations coming together.
How did this start?
So this actually started with myself and some colleagues in North Central London pulling together on this around about 2010, just after the NCPOD report came out, and we sort of mobilised around this and writing pathways together, and we started auditing together and producing materials in 2010. And so that went live in North Central London, which I think would probably be described as the world's first AKI network, and that scaled out across London in late 2011 and into 2012, and that was really down to the enthusiasm and support and vision of my colleagues in the 6 other renal units in London that made that happen. So we went live in 2012, and in 2013 we became part of the strategic clinical network structure for London, and I think there are now AKI networks across most of England as part of that structure.
And so what are your goals?
So our goals are to deliver effective and equitable AKI care across London through strengthening of collaborative working between individuals and across organisations. So we are aiming more specifically to reduce AKI mortality, reduce the burden of CKD from AKI episodes, to reduce the healthcare costs associated with this condition, and finally to improve the patient experience and subjective feelings of wellness that patients experience after an AKI episode. But fundamentally, I guess it's about reducing inequality of healthcare access, such that whether a patient enters a sort of what might be called a flagship foundation teaching hospital with AKI with a very large renal unit, or whether they enter a hospital with less rich clinical resources, they will get the same basic standards of care and have a good experience and a good outcome.
Who are the members of the network? So
Lakin started with voluntary membership, and the membership was something that had to be ratified by the medical directors of the secondary care organisations. So it primarily started in secondary and tertiary care, although we are looking more at primary care involvement. And initially this has gone from voluntary membership to, as part of the strategic clinical network structure, all London hospitals are part of the network. On a practical level, we interact with the AKI lead for each organisation, and in addition we have an oversight pan-London board, and at all points we are multi-professional, multidisciplinary. I think it's important to note that this is not a network of nephrologists. They are the minority group within Lakin. Most of the contributing clinicians are doctors or nurses from critical care or acute medical teams, although the nephrology teams are all represented. And we also have a very strong patient engagement in the project as well.
How does Lakin operate?
So Lakin operates, we currently report to the Strategic Clinical Network Specialist Clinical Leadership Advisory Group, and we've got very strong support from them, and they are led by Neil Ashman, who's the Clinical Director for Renal Services for London. Below that we have a multidisciplinary and geographically representative Lakin board, and we provide a steering group function for Pan-London projects, and in addition are a conduit for sharing of information. And below that we have regional networks led by renal units, so there's 7 renal units in London. In South London, King's and Guy's and St Thomas's work together, and in addition St Helier and George's work together. So there's 2 South London networks and 3 North London networks. These are sublet networks of Lakin, all with their trust leads. It's also worth pointing out that in North West London it's hosted primarily by the North West London Critical Care Network, which is led by Angela Walsh and Ganesh Suntharalingam, and so that's where the sub-regional network sits. So basically 5 sub-regional networks reporting to Lakin board, and we report into the NHS England London regional structure, and specifically to the renal SCLG and Neil Ashman.
What do these clinical networks do?
So clinical networks as a whole are a way of managing patients collaboratively according to common goals across organisational boundaries. And although Lakin doesn't have a specific funded operational function, the principles of that remain. So we are managing against collaboratively agreed pathways, with at least the intention that every patient would experience similar standards of care according to an organised pathway that's been agreed between organisations.
What has Lakin achieved so far?
So within Lakin we have agreed through clinical stakeholder engagement and participation across London a pathway for AKI care that applies to all London patients, and this has been operationalised into guidance in more than 80% of London trusts, and that's supported by a rich and fairly innovative educational resource, including a very comprehensive resource of online resources on londonaki.net, the world's first AKI specific mobile application, educational videos, and of course the Lakin Academy, which is I think the first standing recurring AKI course. And these educational resources point towards the agreed pathway of care in London. In addition, we've had a sharing of a sort of best practice function, a community of practice function. We've run around 25 sub-regional events, getting the clinical teams together to iron out any difficulties with implementing the pathway and to share information. And on top of that, we've run around 10 Lakin boards across London. We've run specific sharing best practice events in biochemistry, innovation and research, pregnancy, and HUS AKI. And in addition, we've got a very large launch event in March 2012, and we're having another very large catch-up event in November 2015. So I think part of this has been sharing best practice and also raising awareness of this condition. In addition, we've been a bit involved in the innovation domain, so as well as mobilising a harmonised AKI care bundle at a regional level, which I think was a first. We've also had the first standardised regional implementation of AKI alerting in North Central London, and slightly more heterogeneous implementation of AKI alerts around 60% of London in advance of the National Patient Safety Alert edict on this, and in addition also the first regional implementation of an AKI community alert to primary care.
The next step's going to be?
So the next steps for Laken, I think we want to move towards a situation where we have much richer data sets, and we've been working with some collaborators in UCL on collating large amounts of hospital data such that we can survey trends in AKI incidence, outcomes, mortality, healthcare expenditure across a lot of London hospitals. I think we now have the largest database of blood tests globally, and we're working in a research domain on trying to utilise that resource for AKI patients. I think there remains a question of whether we could have a stronger operational function as well as actually education and supporting best practice and agreeing patient pathways, whether we were in some way operationally deployed to deliver those pathways through an embedded clinical network teams. That's not something we have the resource to do currently, but is something that has some support in the network as a potential future project. I think a next step is, as well as education and guidance, moving into more formal quality improvement methodologies to drive up the degree of implementation of our guidance and standards is a key next step, and this is something that we've been able to activate through the UCL Partners Patient Safety Programme funding stream from NHS England. So this is actually entirely hosted by UCL. I'm clinical lead for that, but it sits slightly outside of Laken, but we have a resourced Institute of Healthcare Improvement Breakthrough Series collaborative looking at AKI on admission to secondary care, and that's an 18-month programme which will be hopefully supporting improvement in around 9 trusts in North Central London, North East London, Essex and South Hertfordshire. Finally, I think in AKI there is a need for more clinical trials, and although this sits outside somewhat the function of strategic clinical networks research, by having clinical networks we're able to embed basic standards of care and practice such that we can layer innovations on top of that. And we are hopefully going to instigate a clinical trial looking at some technology support for managing this condition with outreach systems, which will hopefully go live in 2016.
Do you think we will see outcomes benefits?
So we are starting to see outcome benefits in London hospitals, and this is some work that we're extending through other hospitals through our research data set. I think it's the challenge in an iterative non-clinical trial implementation is always attributing outcome advantages to stuff that we have actually done. I think that is a challenge, but we are certainly starting to see mortality reduce in more than one organisation in Laken, and this is work, the analysis we're hoping to extend, and we'll hopefully see other outcome benefits in other organisations. And certainly through the structured quality improvement programme, the UCLP project, we've set some very specific outcome breakthroughs that we want to see within the 18-month cycle of that project. So we are certainly now in a position where we can look more effectively at outcomes. We are seeing outcome benefits in some organisations against an increasing instance of AKI, and we will attribute that to local work that we've perhaps supported, and increased national awareness and activity of the national programme and various other things that are going on. I think as this becomes a more data-rich environment, and the renal registry project will support that, we'll be able to track outcomes changes and outcomes variation sort of more precisely going forward.
The UCL AKI Breakthrough Series Collaborative, what is that?
So this is an effort to do something we haven't done in London before, which is a structured quality improvement project or collaborative This is led by UCLP, working with an excellent team including Kate Hall, James Mountford, Mirik Skripak, I will struggle with Mirik's name, and Peter Toohey. And what that is about is using the AKI Breakthrough series model for a regional improvement programme. We are focusing on AKI and admission to secondary care, which is about 50% of the problem, and we are looking at key process measures which are door to recognition and door to therapy. Within door to therapy, we've stratified quality targets in terms of timeliness. So for example, the administration of fluids or antibiotics within 6 hours of passing through the front door of the hospital, relief of obstruction 36 hours. And this is based on consensus within the expert faculty group that we have, and also national guidance. And what we're hoping with is we will see an improvement in these process measures, and this will result in a real hard clinical outcome advantage for patients in these organisations. And what we're aiming for is a 25% mortality reduction at 30 days within this pathway, and a 25% increase in recovery to baseline renal function as well. The AKI Breakthrough model is basically a voluntary participation model. We've got 9 volunteer sites, which will certainly cover, in terms of acute admissions, a population of 2-3 million. The way this is run is we agree common process and outcome measures. They are collated continuously rather than through snapshot audits, and we come together in 3 learning sessions to share our experiences and receive the advice of an expert faculty. And we will track progress over the 12 months that we're active, and then have a summit to assess our impact at the end of this. We're very lucky also to be joined by a number of national and international experts in our faculty, including Mitch Rosner, Donal O'Donoghue, Andrew Lewington, Nick Selby, and Mark Devenold, and Louis Forney. So we're very excited about this project. We're very much up and running. We launched in September 22nd of this year, and we hope in a year's time we're going to start to see some real benefits of that approach.
Is your work with other regions on AKI shared?
So we've been very proactive about sharing our work, and I guess that's has taken that's been done in two ways mainly. So we have presented what we've done fairly widely to other regions and national events, including the UK Renal Association and the Renal CD Forum. And in addition, we've always put all our sort of resources out there for free, freely accessible, and sometimes people have asked to share them, and we always agree to do that. And there is some informal networking going on between the clinical leads of AKI networks nationally. We work very well together as a team, and that's actually been strengthened by the presence of the sort of Think Kidneys national programme, and also something developing called the AKI National Cluster, where the regional teams all come together. So that's been very good. We've not only got people working across teams in London, but between regions sharing information, and we've been very influenced by some of the great work that's gone on elsewhere in the country that we've hopefully been able to take back and try to do in London as well.
Will you continue this work?
So at the moment we're definitely up for continuing more. I'm fairly keen to succession plan the chair role of Lakin at some point, but there's still a lot of enthusiasm in the group. We've probably had our most active year in 2015, and I think we will definitely continue. And we're working very closely with the Think Kidneys national programme through 2016, and I think we will be continuing. I think there is an ongoing need for the AKI network, and I think we will be continuing for the foreseeable future.